Alisertib, as you and most people are probably aware, is a Aurora A kinase inhibitor. And this class of drugs was thought to have very potent effects in inhibiting cells in terms of how they divide in mitosis. We know that Aurora A kinase is upregulated in many kinds of cancers, including lymphoma, and that may help contribute to the misbehavior of these cancer cells. Some early work done by Jonathan Freeberg in all types of non-Hodgkin's lymphoma was interesting for activity in some very aggressive, fast-growing forms of lymphoma, which you might expect for a drug that works by inhibiting cell division. But in that study, they also demonstrated some pretty interesting activity in patients with relapsed and refractory T-cell lymphoma. And as you know, that's a population that is somewhat challenging. Those observations led to an international randomized study of alisertib in patients with peripheral T-cell lymphomas conducted by Millennium Takeda. And that randomized study, which is actually the first randomized study in patients with relapsed or refractory peripheral T-cell lymphoma, was randomized against allowed randomization of alisertib as a single agent against dealer's choice. And the dealer's choice arms included 3 drugs, including Pralatrexate, Romidepsin, and Gemcitabine. The first 2 carry specific indications and approvals for the treatment of patients with relapsed and refractory T-cell lymphoma. The study that I'll be presenting on Monday is going to demonstrate that while alisertib had some good activity in patients with peripheral T-cell lymphoma, it did not beat that comparator arm, meaning that in the primary endpoint, looking for an improvement in progression-free survival, the alisertib arm was not superior to the comparator arm. But the study was interesting for some other findings, and that was that both Pralatrexate and Romidepsin, a smaller number of patients treated with Romidepsin, that those 2 drugs, which are FDA approved in the United States and Pralatrexate at other countries around the world, did exhibit some pretty substantial activity, a little bit higher than the pivotal studies in which they were first registered in this patient population. And if alisertib, in comparison to any of those 3 drugs, was found to be a little bit better, it was probably found to be a little bit better than Gemcitabine, which is somewhat interesting because Gemcitabine is one of those go-to drugs that most physicians like for the treatment of peripheral T-cell lymphoma. There's small data sets that have been collected from the Europeans to suggest that there is good single-agent activity in patients with relapsed refractory peripheral T-cell lymphoma. And so in this particular study, Gemcitabine probably had a little bit more hematologic toxicity, so maybe the dose intensity wasn't quite what you think it should have been. But alisertib did appear to be a little bit better than Gemcitabine, but the really interesting good activity seen with Pralatrexate and Romidepsin in that setting in net made it such that alisertib was not superior to the comparator arm. Of interest, Paul Barr, representing a study conducted by SWOG, recently reported and published results of alisertib as a single agent in this patient population. Again, showing a very good response rate. Hard to say if it was really superior to the other drugs that I mentioned, but it documented and established a very good response rate in that patient population. So moving forward, it's not entirely clear where this is going to move. Our group, Kelly Zula from my group, had published some very nice data showing really interesting synergy of alisertib with Romidepsin, which is approved. And that was recently published. It was a set of preclinical findings. And now Michelle Finale from MD Anderson Cancer Center is in the midst of conducting a phase 1 study looking at the combination of Romidepsin plus alisertib in patients with relapsed and refractory T-cell lymphoma. It's a little early to comment on the activity in any subtype of lymphoma from that phase 1, but she has treated a couple of patients with T-cell lymphoma who seem to have had some responses to date, but we are anxiously looking forward to her completion of that particular trial.